Hey guys, welcome back. This is Russell Linville, Sports PT. We're at Training House. I'm here with a couple of my colleagues. Really smart, knowledgeable guys. We're going to be talking about ACL, when to return to sport. It's a very controversial topic. You see stuff on Twitter all the time, people going back way too early. We know the re-tear rates are extremely high. And one of the things we pride ourselves on here is making sure that we have the right criteria as well as a timeline. We'll dive into this a little later as well, of when is the best time to get someone back to sport with the least risk of re-injury. So if we go around here, these are guys I hope that you will be able to see on my videos in the future. First we have Mike Shirilla. He is a sports physical therapist and he works with USA Soccer, and he's one of our great sports PTs here. Next up is Michael Kiely. He's our strength and conditioning coach. He's also our sports scientist. He's in charge of our biomechanics lab, and he's going to touch on some of the tests that we do here to help determine when people are ready to go back to sport. And finally is Braidy Solie, who's a sports physical therapist, and he has a huge interest in complex knee injuries, and he'll have some great insight, I think, today on some of these topics. So thanks, guys, for being here.
Yeah, thanks. Happy to be here.
All right, so let's just dive right into it. When you get a patient, first day or second day post-op, and the patient comes to you, let's say they're a 15-year-old female soccer player. They come into your office or your clinic, they lay down on the table, they got their big knee brace on, their knees swollen, they're in a lot of pain. Both their parents come and sit down right next to you. And the third thing out of their mouth after hello and nice to meet you is, when do you think I'll be ready to go back to play? What does that discussion look like? And how do you manage that situation? Maybe Mike.
Yeah, I mean, lots of factors. I think first day, they always have a goal, right? They're an athlete, so they want to know what that goal is. So I try not to get too quick to a timeline, and I think we'll touch on this. It's sort of that small goal at first, like the main three things that we need to accomplish first for the next step in the phase, right? So I try to skirt away from the actual, like, hey, you'll be ready in 8 months or for that showcase, because as we'll talk about, we have different criteria that you need to hopefully meet throughout the course of your PT to get back to that. So first day is obviously just building rapport, but on that kind of subject, collaborating with the doctor and sort of really tackling the main things right in front of them, and going, if I did say a timeline, you guys can chime in, it would probably be no earlier than 9 months. With the latest research that we've all been following.
Yeah.
That's my
What do you think,
starting point.
Yeah, I agree. I think that especially in the early phase there, a lot of that is dictated by, how hard the athlete's willing to work for you. So laying down that foundation of that you as the PT, your job is to reinforce the game plan to get that athlete as efficiently as possible to that end stage goal, which is returning to play, but also making them realize that there are these stepwise baby steps that need to happen in a stepwise fashion to get that athlete back to playing sports. So focusing on short-term goals of, whether it's XYZ with extension and quad function and swelling, getting those managed efficiently, that's going to allow them to efficiently get to the next step, which is going to be the strengthening phase, and making that athlete understand that you might not be able to give them an exact timeline per se, but you can give them a ballpark answer, but it really is dictated by how efficiently and how locked in they are on the rehab process.
Yep. Anything to add, or you got?
I don't have much experience with
because you see them later on.
First day post-op.
Yep. So then maybe we can tie into this next question of, we hit phase one goals, swelling, look at swelling, range of motion, those sorts of things. When is it appropriate to start pushing it, maybe in terms of weightlifting or running? And what are some maybe red flags that you guys see or look for that might hold you back from doing those, even though a surgeon's protocol might say, hey, at this point in time, it's okay to start running or jumping or whatever. What are some criteria you guys look for to make sure we're not maybe overdoing?
Jump on that one.
Yeah,
I think what it really boils down to is making sure that you have covered your bases with having good extension range motion as best as you can, and then also having decent quadriceps firing. I know I tend to bias a lot towards quad activation early on, making sure that the knee is really firing well, but also in that time we're trying to manage that swelling. And as those two criteria being met, the athlete might not have a completely silent knee, but if the swelling is showing that it's not reacting to what I'm doing, as in the swelling levels going up throughout the session or something like that, it seems like it's maintaining a baseline. That's where I'm not afraid to go a little bit more into closed chain loading, just to see where that limit seems to be as far as tissue irritability, even if there's a little bit of swelling in there. But again, you got to make sure that you're covering your bases, that the quad muscle is firing properly and have good extension before you start to think about adding some type of mechanical overload to the joint.
Yeah, no, I would agree, and I know we talked about this earlier too. Is every ACL repair, I think sometimes patients get lost. Like, oh, well, my friend had that surgery. Well, did they have a meniscus repair? Did they have other issues going on in there? So that's sort of when the art comes in. I think, in my opinion, early on, is everyone's going to react differently if we have those discussions. People come in like, how much are they tolerating the pain? You know, like mentally, how are they perceiving all that? There's a lot of factors early on that we really have to manage, because we have some that swelling's like, they usually have one issue that's sort of their hurdle, right? Like, I just swell a lot, or you have the people that have everything, you know, like they got pain, they got swelling, and they can't fire their quad. So, but obviously, I think some of the troubles we've had is when you're skipping the important, like if you don't get that knee extension, it's gonna slow us down, and we have to get that back. So the sooner we can harp on getting full extension, getting that knee quiet, getting that quad to fire, I think that's where we've seen the best success. And then once that happens, then like you said, then you can start testing close chain things. And even that, it's not just textbook, you know, cookie cutter stuff. Because some people some people tolerate a lot of load, some people don't at all. So it's very personalized, and you just really have to be fine tuned on making sure that you're checking all those things every time they come in.
Yes. So Kiely, you know, to tie this into the sports performance side of this, in sports science, we do something very unique here. We test our athletes at around 3 months, around 6 months, around 9 months, and maybe you can touch on the test that we kind of collectively thought was important, and that you're seeing some of the issues you might see with some of these people early on at 3 months that might start these things too early.
Yeah, definitely. So at 3 months, we do start our return to play testing. We'll do a isometric quadricep test at 90 degrees and a single leg squat under a motion capture. And so right now, what our data is kind of saying is that our average limb symmetry index, so surgical limb average peak torque divided by non-surgical limb average peak torque, is around 65%. So that's our baseline for 3 months. And so when an athlete comes in at 3 months, our criteria to say you're on track is, are you at 65% quad symmetry, and do you have a symmetrical above 85% single leg squat strategy, right? We look for peak knee flexion angle, trunk flexion angle, and we look at their strategy and see, are they comfortable loading that knee in a slow, controlled, closed chain motion? And then what we see there, based on strength, range of motion, and is the knee quiet, then we'll give recommendations to start loading. And one thing I kind of want to touch on is what is loading, right? I think that people think, you know, loading is a ton of weight, right? Or loading is running or jogging. And I think that they're very, very different. And one thing that I believe is load is body weight with increased time retention and increasing range of motion. And those simple things, I think, can be utilized. And people are constantly thinking that load is either you're running or you're lifting. And I think we get away from sometimes the fact that doing a split squat with 30-second isometric at 90 degrees knee flexion is load on the joint that is safe, and it's stimulating neural patterns and muscle activation that will be ultimately preferential.
Absolutely. I think that what you touched on at the time on retention, utilizing isometric loading early on, especially if you do have a little bit of inflammation or confusion in the knee, is a really safe way to provide some type of a mechanical stimulus to those soft tissues. Because the issue that I commonly run into when I'm dealing with ACLs early on is the fact that they tend to have a swelling that lingers. Maybe that's just their biology or their anatomy, is they tend to be a little bit more of a sweller. Sometimes you can forget that isometric loading is a nice way where you can fatigue out some muscle fibers and get some extra activation on different muscle groups by just simply having to hold something like a bodyweight iso hold.
Yeah, I mean, that's the thing, is how can, especially as a strength coach, and we're starting to do more early stage strength conditioning, and so kind of finding that battle of what is a minimal effective dose to encourage loading and adaptation, positive adaptation, without making it knee angry. And it's a tough battle, especially with the patella tendon mass, where they're already, the extensor mechanism is already so, for lack of a better term, effective. Yeah, absolutely.
Great. Do you have anything to touch on that, or they touch on this basis? I think one of the
bases there.
Yeah, one of the greatest things that I think physical therapists here have benefited from is having really knowledgeable strength conditioning coaches here that can tie in, when do we transition from rehab mindset to a more strength and conditioning mindset. So that one, it helps the athlete figure out when they're prepared and ready to return to sport. And two, it lets the PT progress with comfort, knowing we're doing the right things, we're checking in at the right times. So really important to do some of these check-ins every couple of months to make sure we're on the right track. So next up, so this is the big question. You know, you brought up earlier friends that may have both torn their ACL, and they talk to them, and they, you know, one friend's a year out, the other friend's a month out, and they ask them, you know, usually we see this in our soccer girls, where, you know, they're on the same team, and 2 or 3 of the girls on the team or in the organization has had an ACL tear. And all of them have different return to sports. They have all different surgeons, they have different PTs, they're spread out and they're getting a lot of different information. And then the patient that we see hears all these things and has no idea. They're really confused on what should they expect in terms of a timeline. And you know, we're kind of, I guess, harping on this, a lot of criteria based, but is this timeline based or is this criteria based? What do you think?
Yeah, I mean, I think it's definitely criteria based. I think that, you know, that's something that we have here that's a challenge. It's a good challenge, and I think we're there are still just the timeline of I run at 3 months, I jump at 4, I start getting back into practice at 6 months. That's, I think those days are sort of changing. I mean, we're not seeing that with the research and with what we're doing here. I think we have the luxury of having a state-of-the-art biomechanics lab and using that data to actually help our patients, which is amazing, but it also comes with the, you know, good burden for us, or challenge in the sense of we have this criteria-based stuff, and if that's not the norm, how do we change that in the public with our patients? So I mean, for me, I think I try to be very upfront, and I think I continue to try to be better early on. What is the expectation? Because if they buy into that, I'm not throwing them for a loop at 8 months and they're not ready to go back to play for that showcase. So the sooner you can get them on board with like, this is really the best thing so that you don't have another re-tear, is super important. And I'm touching on when people do go back and they go, well, my friend's back playing. I'm like, well, I don't know exactly what they've had, or I can just say, I'm looking out for your best interest. I can tell you that most likely they're probably still in a very vulnerable position, and they may make it through, but they still are probably at a very, very high risk. And again, we talk about this too, is we just want to educate our patients and their parents to know of those risks if they do want to go back in the final stages. And so we've had those not fun conversations, but I have them because I care about my patients and I don't want them to get re-injured.
Yeah, I'd say the hardest part.
That's the trick. So with all this information we have, we're trying to change the culture of how we rehab our ACLs, because I think all PTs would say it's not been good enough. With how many people are getting re-injured, and it's changing their lives and their careers as any sport. So I like the challenge that we're taking on, but it comes with its pushback struggles.
Yeah, the hardest thing that I've had to do here is we get so much data. It's a blessing and a curse, right? Because I think ignorance is bliss when, you know, from an observational standpoint, someone looks good, they land well, they get good knee flexion depth, they're not diving into valgus, they can spring out of the position, and then we look and maybe their force plate data is off, or under motion capture, we can really slow down and analyze the movement. We're seeing a big Trendelenburg or something like that that might be a risk factor. And you know, this is the hardest conversation I've had to have with people is, no, right now we can't say that you're ready to go back, even though you're 7 months out and you feel really good and your knee's not swelling anymore. And here's why. And I think a lot of the families and patients are really receptive to it. There's always some that you're fighting for so bad, and they feel bad when you tell them that you can't, because there's some expectation they've already had in their head. So when we think about criterion versus timeline, I think all of us would agree there's both those components are really important. So when do you think is too soon to go back? Like, what's the cutoff of too soon if we're just looking at timeline? And what, in your head, which you might never tell a patient, if we're kind of diving into your own brains here, what is your ideal time that you think someone should go back? And let's again use the example of a 15-year-old female soccer player.
So 15 female soccer. Oh yeah. I was gonna say, well, it depends on sport, right?
Yeah.
I mean, the literature's out there that under 6 months, the biology of the tissues that were repaired are not what they once were. They're not there yet, right? There's some literature that's saying that that graft isn't the full ligament until 18 to 24 months, right? So if we're talking pure biology of the ligament, I would say 18 months, right?
Yeah.
But no, that's a career-ending injury, right? And we know people can go back early and not repair, right? It's 30%. So I think that anything under 6 months is just not good, right?
Yeah.
And then at 6 months, post 6 months, right? If you have if you meet criteria, right? Then depending on the level of activity, the sport, and the conversation can be had. But I would say prior to 6 months, in my opinion, the conversation should be had.
Well, definitely not for a 15-year-old.
Definitely not for
If you're a professional, I mean, people see the NFL guys go back faster. That's their career. There's a lot more at stake, and they know the risks of that. But for a 15-year-old, even a 16 or 18-year-old, I would still be. I've gotten more conservative in my approach, for sure. And I think I'm doing my patients a better favor by that. But I also would hark back on your previous question. It was interesting, like blessing of having too much information. I'll be honest with you, 2 years ago, I was clearing people a lot quicker. So what do? We did the hop test. We did a couple other things, and they look good running. Now we have way more things, and so it's changing the game, which is good. So,
And it is, but there's still not enough information out there. I mean, we could have people meet all criteria, go back 9 months, all criteria met, and still tell you. You have someone go back 6 months, not meet criteria, and not tell you. So it's.
But you'd like to say that yes, they did that, and it can happen. But you'd like to say that we hopefully made that piece of the pie of risk as low as possible.
Yeah, exactly.
Unfortunately,
Exactly.
it just didn't. Cards were dealt poorly for that athlete. But I think too many people are not checking the boxes of the things we can modify, especially if you talk about a 15-year-old female soccer player. There are so many non-modifiable things that we can't change that are just already innate to be very high risk. Without an ACL tear, and now you already had one, I mean, it's really, really high. So I think we have to do everything that we can as PTs or as a group collectively in sports medicine to make sure that goes down. We can go into dynamic more, that's a different story.
Yeah. Any other input on timing, Braidy?
I'd just say, we talk about the adolescent female soccer player. I mean, that is one of the highest risk profiles that we have in the sport right now, from what our literature is saying. I don't take a re-injury very lightly. I don't think that the athlete does, and I really don't think their joint does either. So, me as a physical therapist, I think the thought, again, with a lot of, we talk about return to play, is trying to get that athlete to begin to end in mind and realize that there are some modifiables that we can reach with our criteria. But we also want to be planning, around the fact that athlete potentially is planning on going back to sports. So there's the other talk of, we talk about specificity in training and making sure that athlete, when they're able to, is getting some exposure within a return to play group or a training environment where they're doing some type of strength and conditioning. And then also having a game plan to gradually ramp up their exposures within a practice setting that's sports specific. And I think those have value too in mitigating risk on top of just passing our performance tests. We need to have a good holistic plan that allows that athlete to transfer from being a patient into more of a performance strength and conditioning setting, and then return to practice or an exposure where they can get their body awareness and their legs about them in a very sports specific manner before deciding to take that leap up to a competitive match play or competitive soccer play. And that's where, in my mind, if you look at an ideal situation, it is an athlete that's, maybe in PT up until that 5 to 6 month mark, and then they're getting a solid maybe 8 to 12 weeks within a return to play or a strength and conditioning type program. And then off of that, we're monitoring those return to play criteria, potentially getting that athlete back involved with their team, doing some controlled practice situations where they're gradually ramping up some of that sports specific exposure. And then eventually, as a team, deciding when's the best option to let that athlete go back to competitive play, and then how we delegate those exposure time or minutes as they do that, knowing in mind that we do have good data that if we can get their performance up in some of our return to play criteria, that's going to help them perform better as an athlete, but it's also going to reduce the risk of injury, knowing that they're already at a higher risk with their athlete profile. So
Yeah.
there's a lot that goes into, I think, our ideal situation. Do we ever hit that? I'd say rarely, but those are conversations that when you do have that opportunity, it's good to grab hold of those, because every once in a while, we will have an athlete that's looking good at 5 months or 6 months and has that opportunity and the financial resources to get into a good strength and conditioning program. And we need to do our best job of, number one, talking with the professionals that are running those strength and conditioning programs, but then also working as a team to gradually ramp up some of that exposure time with practice and actually return to competition plan.
I think you bring up a great point with the concept of gradual return. And I right now, from what I hear, I'm not a physical therapist. I only see them in the lab, and so patients like it black and white right now, and they're like, "Oh, I'm returning to play, therefore I am 100% to go." Right?
I was going to bring up that exact same.
It's even in anything in life, right? I mean, you just take algebra before you take calculus, right? You in the weight room, you don't just throw a bunch of weight on the bar the first day, right? You start with fundamentals and you progress slowly, right? Whether it's linear, undulating, modified, whatever you want to call it, right? There is a periodization to adaptation, and so it's critical that return to play process is a progressive overload.
Oh, and that's
For both the mind and the body.
For the mind and the body, absolutely.
for sure. And I think that's the tricky part is when they do, oh, I'm going to go to this showcase.
Yeah.
We've all had those talks like, well, you're cleared now, but you haven't even played in any sort of competitive, like, you're not just going to go play. I mean, it's like in baseball, you're going to go play in the minors and like build, right?
Yeah.
You're not just going to go play with players that are at their highest right now and get thrown in that the speed of the game is going to be too fast. It's like they don't really. That's sort of, I still think, the tricky part for us is because now you got to there's more people you got to incorporate, like coaches, and knowing like the importance of like they're back, but it's got to be graded, they got to be closely monitored, and we're not there. You know, they're now out of our facilities. We can try to do that, but every coach practices different, monitors their athletes different, and trying to put limits to like, hey, this is our star player, we're gonna play her all the games, you know, and we've all had that. Like, that's still going to be a real challenge. If you're in a pro team, I mean, they're watching you every day, and okay, you're going to do a simulated game or you're going to play contact. So that's the tricky thing I think with the youth soccer is once they're cleared, they're really not fully cleared. They still have months to build into to actually play a full game at the highest level, because a lot of these elite soccer players, you can't just jump right into a DA game.
And there's no clear way to do it, right? It's very individualized.
I mean, how everyone responds.
Exactly. It's not, okay, after, you know, like right now we set some guidelines saying, all right, you're going to get 15 minutes, then 30, then 45, then 90, or whatever our progression is. But it's going to be different for each person. They might be in each phase differently. And so that's the hardest part is maintaining that communication to ensure that graded progression happens.
Yes. And it's so critical, because if you look at we have a couple of studies looking at re-injury rates, and when they happen, whether you meet criteria or you don't meet criteria, most re-injuries are going to happen very early when the athlete returns to competitive play. And I think part of that is it's a disconnect, and it's the trifle of kind of being in an outpatient physical therapy clinic or performance clinic and having that athlete with a team somewhere else. Is you lose that gradual ramp for return to play, where they're meeting criteria and things in the clinic and trying to progress, sport specific stuff with the strength and conditioning program, but then all of a sudden they leave your facility and they're with their team, and no one can really is in charge or taking ownership of how to delegate that exposure back to competition where those re-injuries are happening. And it's a problem. It really is.
So let's try to dive into your brain. Ideal timeline. No other factors you're considering. You're saying, okay, 15-year-old soccer player at this timeline, I feel comfortable.
Comfortable with what? Starting the return to play
Playing.
or playing in a
Playing
game?
competitive soccer.
Yeah.
How much time in the game?
A full game. Full game.
Okay.
So,
I like this.
what do you think?
I'm gonna go really conservative and be honest. I mean, I don't like to put a timeline on anything. I'll just preface that.
So the reason I bring this up and why you feel uncomfortable is because this is why timelines shouldn't matter to you athletes as much, and it should, because you want to have an expectation, right? But just know that this is something we struggle with. So what do you?
Well,
what do you think?
on that front, I think this is a good one. Like, when people go like, not every same athlete, like, just because I have to wear a size 12 foot, my foot's totally different than somebody else that has a size 12. So that's every athlete's different. and we need to approach it that way. So that's why, you know, like, not, oh, you're size 12, well, that shoe will fit you well too. Not the case. So the same thing, and that's what like good sports medicine do. It has to be individualized.
Yeah.
So there's so many factors that are in there, but I would say if you had to like pin me down and give you a solid answer, I would probably say if everything went perfect, probably 10 months.
Okay. On a perfect.
Like
Perfect
full
scenario.
game.
All right.
Okay.
So that's aggressive.
I'm speaking like a strength coach, right? And so I'm looking at it in terms of phases, right? So if I'm going to build a full strength summer, an off season, right? I'm thinking in terms of I've got 3 months with an athlete, right, to get them as prepared as possible to start sport specific speed loading, right? So I look at that and I'm thinking 12 weeks, right? 3 weeks per phase plus a deload, all right? So, and we're ramping up, playing around with our volumes, our intensities.
This is after sports PTs ended and they met all their criteria for us.
Yes, no, I'm just kind of laying the foundation, right? So
Okay.
I'm thinking, so
That's a long answer, guys.
this is a long answer, and so I'm
No,
me and Chris are in charge of the return to play strength and conditioning here, and so we get the athletes at 6 months, right? And we see them 6 to 9. Our goal is to get them to that point. So in my eyes, I look at, according to the biology when it's out there, like 9 months is when you're going to start introducing playing on the field, right? So if I look at it like my 12-week strength protocol, right? I'm thinking 9 months you start that progression. You're in phase 1, month 1. Month 2, you're picking up a little bit. You're increasing time, maybe increase reactivity, increasing contact. And then month 3, you're starting to pick up your speed, all right? So in my eyes, I want 12 months is when you're going back to play a full game unrestricted. Because I look at that, if at 9 months, right, you've met all criteria and you're starting to play, you know, you're practicing stuff like that, I think that it takes that much time for your body to adapt to full speed. And so with undulation throughout to, you know, general adaptation principles, right, I think 12 months is my opinion, if I put a time on it based on that.
I'd echo that, Kylie. I think that in my mind, like we talked about the biological factors, and if I don't know this athlete, I'm gonna put a timeline on it. I feel that 12 months is a reasonable amount of time for patellar tendon graft for me to feel like I trust that graft from a biological standpoint. And then if I think backwards from where 12 months is at on that return to play timeline, I'm thinking that most athletes are going to be doing okay between 6 and 7 months after an ACL reconstruction, where I feel like I could ramp up some sports-specific type training, whether that's within our strength and conditioning group or some on-field stuff, and that's still going to allow them to have a good 3 to 4 months to play around getting better outside of one-on-one with me and PT potentially, and that's where I come from from a 12-month standpoint. So I feel like that will allow them to get a little bit of that specificity of being back and playing and potentially practicing and ramping up some of that higher intensity practice and not having their knee, you know, super sore still from it being early post-op, and not doing just traditional PT stuff and getting actually some more specific movement patterns under the belt.
So yeah, for me, so those are all great points. I hesitate to tell people less than a year. There's just so many of the factors that we talked about here. If you think about, so there's a study by Shaw et al. That came out, I think it's 2017, that looks at NFL return to play, and when they actually get back timeline-wise, it's between 10 and a half and 12 and a half months. And these are NFL guys that are training they're in the training room every single day for hours a day. They have a full medical staff that's up at their beck and call, essentially, rehabbing them, and they're getting back in 10 and a half to 12 and a half months. 14% of those surgeons only 14% of the surgeons in that were asked in that study would let them go back before 6 months. So even the NFL guys we talked about, coming back before 6 months is highly unrealistic, and these are huge, powerful guys that can move well. And so if we go back to your 15-year-old soccer player, if all I had was timeline and I said, okay, what does the data show that might put her at the least amount of risk to go back? I don't know anything else. I would say, and I think this was Tim Hewitt that came out with this study, looking at maybe the return to sport should be, for that age group, is 2 years. And that's just, we think about that. I think you touched on it earlier, or you did, that, man, if this is a high school sophomore, now we're not letting her go back to maybe after her senior year. And so is that realistic or not? I don't know, but I think we bring a biological standpoint and a motor control standpoint, this 15-year-old females, this might be the first coaching they get in terms of how to move better. And now we're trying to overcome their normal motor pattern development. They get injured, that's interrupted, and now they're coming back from injury, and we expect them to be ready by 7 or 8 months. I think that's too soon. So enjoy all those answers. We can talk about this forever. We might do another video, but appreciate you guys' time chiming in. Is there anything else, any closing remarks you want to have for the listeners out there?
Yeah, I do actually. So,
Sure he does.
Of course I do. I think that, we talk about collaboration, right, through this process.
Yeah.
And I think it's one of those things, especially that I'm learning, as, being part of the lab and being involved 3, 6, and 9 months, is that everyone has a place and we don't have the answers. And so I think that it's really, really critical right now that it is a team clearance, right? And I think that criteria has to be, starting with is the joint, right? Joint, range of motion, pain, diffusion, and graft structure. Is it all solid? Boom, that's level 1, okay? Then, basic movement patterns, basic quad activation, stuff like that is in that early rehab. Boom, that's number 2. And then that gray area of when we start a combination of PT and strength conditioning. All right, do we have the basic strength loading patterns? And then going into the lab and stuff like that, but then progressing when we're going into sports performance, right? There should be a stage with a sports performance coach where it's unrestricted sports performance, right? And then we get the sport coach involved and explain the concept of the grade of progression. And so we'll never be able to, I never want to say never, because there is a way to simplify this for people to understand, right? The fact that the doc understands what the lab is putting out, right? That the coach of the sport understands what's happening a little bit at the tissue level from the PT, right?
Yeah.
And I think that information can be communicated effectively, and that will help this timeline, because then if you have this, essentially an army, right, of 6 to 7 people speaking for the betterment of this athlete, our re-injury rates potentially will go down, because it becomes an education piece on the fact that it is time, criteria, and what are the athlete's goals, right? And if you have everybody explain the same message and you have an open conversation about it, and you might ruffle some feathers with each other, but the fact that you can all have evidence or justification for your decisions, I think that is super critical, and I think that that's starting to become a possibility. But it's going to take open minds that are willing to kind of understand information that they never had to. That's my little last tip for this.
And I'd say, just kind of piggybacking off that, is the power of team approaches is the beauty of different minds doing things. And then also, realizing that even within that group, there's always the unknown or the risk associated with just bad luck and a lot of non-modifiable things. So just knowing that, what you can do, trying to optimize what you can do, but then also knowing that, there's always that uncertainty that exists with sport play, and injuries are part of sport, and acknowledging that if you do have a poor outcome as a provider and athlete, sometimes it's not always something that can be modified or changed, but it's important to make sure that you're taking the time to understand what you can do about it from whether you're a provider, a therapist, a physician, or an athlete, to make sure that you cover those bases so that when you do go back, you don't have any what ifs about it if you do have injury.
All right.
Thank you, boys.
Well, guys, this is the Become a Better Human project. We're talking about ACL, return to sport. When do you do it? Thank you guys for tuning in. Hope to have these guys back. Obviously, they're experts. Can you tell? I mean, I love working with these guys. Make me better every day. Hopefully, it'll make you better. And I'm going to put on the show notes their social media, Twitter handles and Instagram, all that stuff, so you can follow them, get on the soch, and check them out. They got some good data they put out there too. So if you like this video, click subscribe and share this around with your friends, your PT strength friends, and let's spread the word. Thanks, guys.